Okay, so endocrine system 2, we'll go over the anatomy of each gland, including location, the hormones secreted by each gland, the target tissues, and examples of target tissue responses to each hormone. We'll talk about the mechanism that regulates hormone secretion by specific glands with examples given. For selected hormones, we'll talk about the causes and consequences of either having a hyper or hyposecretion, and then we'll talk about lots of diseases that result from either a hyper or hyposecretion of those hormones. Okay. So in your lecture notes, you have my beautiful drawing of the hypothalamus and pituitary gland. Not pretty at all, but it's the best that I can do. Previous versions looked a lot worse. But the hypothalamus is right there at the top. That's part of our brain. And so which one of the 4 main tissue types do you think makes up the hypothalamus? Nervous tissue. So it's made up of nervous tissue. Then we have the posterior pituitary, which is also made from nervous tissue. The only true endocrine gland on this diagram is the anterior pituitary. And which of the 4 main tissue types should our endocrine glands be made out of? Epithelial. So our anterior pituitary is made from epithelial tissue. So we're going to talk about hormone release through the anterior pituitary gland first and how that works. So we have our hypothalamus again. Posterior pituitary is the lobe of the pituitary gland on the posterior side. Obviously, the anterior pituitary is the lobe on the anterior side. And then we have some neurons. So the way that the anterior pituitary releases its hormones is that it communicates with neurons from the hypothalamus. And those are called hypothalamic neurons. Those are going to secrete their hormones into what's called a capillary plexus. We have a primary capillary plexus and a secondary capillary plexus. Now, there's a little space in your notes because the hypothalamic neurons, they release what we call neurohormones. Now, when you learned about like the neuromuscular junction and such in Bio 32, what was the name of the chemicals that got released by the neurons at the axon terminals? Well, acetylcholine is a type of what? Neurotransmitter, right? So these chemicals here, they're still being produced by a neuron, but it doesn't go into a synapse to another neuron or into a synapse into another muscle. This is being secreted into the blood. And so because it's secreted into the blood, and we know that endocrine glands travel via the blood, these are considered hormones, but because they come from a neuron instead of an epithelial cell, we call them neurohormones. Okay, so it's not a neurotransmitter. The reason for it not being a neurotransmitter, and NT stands for neurotransmitter, so these are not neurotransmitters because they travel via the blood and not a synapse like we've seen before with neurotransmitters. Does that make sense why we call them neurohormones? Okay. So in your notes, it talks about how the anterior pituitary has no direct nerve connection with the hypothalamus. You'll see it is going to communicate via these capillary plexuses. Yeah?
You said the squiggly clumps were called what?
Capillary plexus. So I won't test you on this anatomy here, but I'll write it down. This is the primary capillary plexus. This down here is the secondary capillary plexus. And then this entire thing here with the 2 plexuses is considered a capillary portal system. So again, the anterior pituitary has no direct nerve connection with the hypothalamus. It's going to communicate with the hypothalamus through this portal system. So the neurohormones are secreted by the hypothalamus and then carried to the anterior pituitary through this portal system. Does anybody remember what skeletal structure the pituitary gland sits in the skull? Cella turcica. Just a little review. So how this works, is that the hypothalamic neurons are going to release a neurohormone. Those are those purple dots there. Those neurohormones are going to travel down that portal system to a different set of cells in that secondary capillary plexus. And the secondary capillary plexus, these cells here, these are epithelial cells, little blue circles are epithelial cells. They will have a receptor for that hormone. So again, neurohormones travel down this portal system. Those neurohormones are going to bind to receptors on epithelial cells in the anterior pituitary gland. And then once that hormone binds, it's going to trigger the release of the next hormone from the anterior pituitary gland. And then this right here, this little arrow, this is going to be the blood supply to the body. Okay, so again, neurohormone gets produced and released. It travels down this portal system to some epithelial cells in the anterior pituitary. Those epithelial cells will have a receptor for that neurohormone. And once that neurohormone binds, a second set of hormones is going to get released to the rest of the body. Yes?
So where exactly are the receptors located that the neurohormones?
So they'll be on the surface. So most of the hormones that we talk about here will have surface receptors. Most of the hormones we talk about are amino acid-based hormones. The only lipid-based hormones that we're going to talk about is cortisol, aldosterone, and some androgens, which we'll talk about later. Everything else you can consider being amino acid-based. So they will bind to a surface receptor. Yeah? Yes, it is. Any questions on this before I move to the next slide?
That's the first capillary plexus, and that's the second degree capillary plexus.
Uh-huh. Yeah. Okay. So there are 6 different neurohormones from the hypothalamus that target 6 different populations in the anterior pituitary gland. Because each one of those neurohormones are going to bind to a specific receptor. Each one of those hormones will have a different receptor on those epithelial cells found in the anterior pituitary. Most of these neurohormones from the hypothalamus are either going to be releasing or inhibitory, meaning they're going to cause the release of a hormone, or they're going to inhibit or slow down the release of a hormone. Luckily for you, you don't have to know all 6. We're only going to focus on 2 of those 6 this semester. One of them being growth hormone releasing hormone, meaning it causes the release of growth hormone. And then we have thyroid releasing hormone. And thyroid releasing hormone is going to eventually cause the release of thyroid hormone. Okay. So questions on that so far? Okay. So hormones that are secreted by the anterior pituitary include growth hormone. And again, this is triggered by growth hormone releasing hormone. So growth hormone releasing hormone comes from the hypothalamus. It travels down that portal system to some epithelial cells in the anterior pituitary. And then once growth hormone releasing hormone binds, then growth hormone can be released from the anterior pituitary. So I'll show you how that works. So let's say those purple dots there, that's growth hormone releasing hormone. So these are GHRH. This is just an example. And then GHRH travels down that capillary portal system to some epithelial cells in the anterior pituitary. Those epithelial cells will have a receptor for GHRH. And as soon as that hormone binds, then we can have growth hormone being released down here. So does that make sense? We have one hormone controlling the release of a second hormone. Okay. Same concept with thyroid stimulating hormone. Thyroid stimulating hormone, this is from the anterior pituitary. Its release is triggered by thyroid releasing hormone. So thyroid releasing hormone gets released by the hypothalamus. It travels down that portal system, binds to a thyroid releasing hormone receptor down there, and then the anterior pituitary gland can then release thyroid stimulating hormone. Okay, there's going to be another step to that where thyroid stimulating hormone then goes to the thyroid gland, binds to receptors there, and then the thyroid gland can then release thyroid hormone. So it's like this cascade of events that occur. So again, it targets the thyroid releasing hormone, is going to trigger the release of thyroid stimulating hormone. Then thyroid stimulating hormone causes the release of thyroid hormone from the thyroid gland. So what kind of stimulus causes the release from the thyroid gland? What is it? Hormonal, right? You in that PLA that you did over the weekend, you learned about humoral stimulus, neurostimulus, and hormonal stimulus. This would be considered a hormonal stimulus because one hormone causes the release of a second hormone, or third in this case. This would be hormonal stimulation. Questions about that? So we'll go through that again. And this time I made it a different color so we can think that they're a different hormone. So this is thyroid releasing hormone. Gets released by the hypothalamic neurons. This is a neurohormone. It travels down that capillary portal system, binds to cells at the anterior pituitary that have a receptor for thyroid releasing hormone, and then thyroid stimulating hormone can then be released. That will travel throughout the body via the blood until it reaches cells of the thyroid gland. And when thyroid stimulating hormone binds to those receptors in the thyroid gland, then the thyroid gland can release thyroid hormone. Now, the other cells that are released by the anterior pituitary, we won't talk about how the hypothalamus controls those ones because we're only going to focus on hypothalamic control with these two. But there are still some other hormones that get released from the anterior pituitary. That includes adrenocorticotropic hormone that we talked a little bit about last week. This triggers the release of cortisol, so it's involved in our stress response, and we'll talk about more about that towards the end of the lecture. Follicle stimulating hormone gets released here at the anterior pituitary. It's going to control follicle growth at the ovaries, so the growth and development of the egg and follicle. And then also it's going to have some control over sperm production. But we'll talk more about those functions when we get to the reproductive system. And we have luteinizing hormone. We talked about this a little bit on Wednesday as well. It's going to be involved heavily in triggering ovulation. And then prolactin is the last one. This one is specifically for breast milk production specifically. So make sure you underline or highlight that it's breast milk production because there's another hormone that controls the release of that breast milk. So this is only for production, not for secretion. All right, so questions about how the anterior pituitary gland works. Okay. So now the posterior pituitary gland works a little bit different. So we still have hypothalamic neurons producing neurohormones, but instead of using a portal system, they're going to secrete those neurohormones directly into the blood supply that's going out to the body. Okay, so there's no epithelial cells, there's no middleman, nothing like that, because we talked about before how the posterior pituitary gland is made from what kind of tissue? Nervous tissue. So the posterior pituitary gland really is not a true endocrine gland because it does not have epithelial cells. So in this case, the hypothalamic neurons for the posterior pituitary secretes NH for neurohormones, secretes neurohormones directly into the body's blood supply. So in your notes it mentions that there's no epithelial cells found at the posterior pituitary, so there's no middle person or no capillary system for it to communicate with. So really, the posterior pituitary is more as a storage for these hormones that are being produced by the hypothalamus. Okay, they're just a storage area. They're not doing any production or anything like that. They're just waiting for the cue to release their hormone. So one thing that we're going to learn about here in a couple slides is that for every hormone, and I'll come back to this in a second, for every hormone, we need to know what the secreting organ is and then what the target organ or target cell is. Okay, so for like the thyroid stimulating hormone, the secreting organ is the anterior pituitary gland. That's where it comes from, thyroid stimulating hormone. And then the target gland or target cell is going to be the thyroid gland. So you want to know what the secreting organ is and then what the target organ or target cells are for every single hormone. Okay, so for hormones of the anterior pituitary, the secreting organ is the anterior pituitary. When we talk about the posterior pituitary, though, it doesn't it doesn't produce its own hormones. So when we talk about the posterior pituitary, the secreting organ in this case is going to be the hypothalamus / posterior pituitary. Because they're kind of like a team. The hypothalamus produces the hormones while the posterior pituitary releases those hormones. Okay, so you can't mention one without the other. So the secreting organ here is both of them. Questions about that? Okay, the neurohormones that are released here, and we'll talk about these more in detail. So neurohormones released at the posterior pituitary include oxytocin. And I'll mention this now just because we just talked about prolactin being for breast milk production. Oxytocin, among other things we'll talk about later, is for breast milk, what's called let down. Or you can say breast milk released, you can say the expelling of breast milk, any one of those variations would be fine. But oxytocin is for breast milk let down or release, while prolactin is for breast milk production. So make sure you get those two straight when you're studying. The other hormone that's produced at the posterior pituitary is also ADH, which stands for antidiuretic hormone. And we'll talk about that more and how it influences blood pressure later in this lecture. So questions about anterior pituitary versus posterior pituitary function? Yeah.
So for the posterior pituitary, what's the target?
So for oxytocin, that the secreting organ for here is going to be the hypothalamus / posterior pituitary. But for breast milk letdown, the target would be the mammary glands. We'll talk about more how it's involved in labor, and when it's involved in labor, the target would then be the uterus. And then for ADH, it works on the kidneys. Antidiuretic hormone is for controlling urine production, so the target there would be the kidneys. But we'll talk about that more later in the lecture. Questions there? Yeah. Oh, it's just like a bullet point.
Oh.
Sorry. Here, I'll fill it.
You said you made a secreting organ, and I forgot the last.
Target organ. Yeah. Any other questions? Yeah.
So since there's no capillaries, what's that reference?
That is a capillary system because you always have to release into a capillary, but then it goes immediately out to the body. It's not a portal system like the other one. It's just a bed of capillaries. Okay, so overview of the endocrine glands. You do not have to list the pineal gland. You learned about that in BIOL 32. Helps regulate sleep cycles and such, but we won't talk about that this semester. But we do have the hypothalamus, which is in the brain. Pituitary gland, also in the brain. Thyroid gland is on the anterior side of the lower neck. Your parathyroid glands are actually on the back side of the thyroid gland, and I'll show you that in a couple of slides here. The thymus gland, which you guys should have identified in lab last week, is on the chest area, upper chest. We really only find that in our infant models because as you age, that organ is going to atrophy or break down. Okay, we'll talk more about its function, but it's to develop your immune system, specifically your T cells. So once you get to be an adult and you've been exposed to a lot of the viruses and bacteria that you are going to be exposed to in your life, that gets smaller. The need for it is less. Okay, so it ends up atrophying or degenerating over time. Then we have your adrenal glands on top of the kidneys. We have your pancreas. Now, what's special about the pancreas and the ovaries and the testes, all of these also have exocrine function. So these all will produce hormones, which is their endocrine function, but then their exocrine function. For the pancreas, it produces digestive enzymes that get put into your digestive tract. Remember, with exocrine glands, they are going to release their product onto an internal or external surface, the internal surface here being the digestive tract. And then the exocrine function for both the ovary and testes, so your egg and sperm. But they'll also produce hormones like estrogens and testosterone. Yeah.
Does that also apply for the placenta and or no?
The placenta is a temporary organ, so we wouldn't talk about it here. We will talk about it when we get to the reproductive system. But yeah, it does produce its own hormones. And then we do kind of excrete it, so I would see how you would come to that, but we'll talk about that with reproductive. Oh, and then make sure you remember to note that for the pituitary gland, only the anterior pituitary has epithelial cells. And so it's the only one that's considered a true endocrine organ. So I'll give you a minute to write this stuff down. That computer's huge. Okay, who still needs time to write this down? Okay, go ahead. Yes.
Adrenal glands also
Adrenal glands do not. They're only going to produce hormones.
is it the pancreas?
Pancreas does, yeah. The pancreas has exocrine function, so do the ovaries and testes, but not the adrenal glands. And then the kidneys are actually a endocrine gland too, very minimally, but we'll talk about that more when we get to blood. Okay, anybody else at any time? Okay. So we'll talk a little bit about epithelial tissue and cancer. What are some general functions of epithelial tissue? Secretion is one big one. Absorption is another one. So does anybody remember, this is a very long time ago, your very, very first BIOL 32 lab, you did a activity with an apple, right? And you looked at the outside and the inside of the apple. Do you remember which necessary life function that was displaying? Yeah, but there was a specific life function. You have to maintain something. Yeah, so boundaries, maintaining boundaries. So one of the big things that epithelial tissue does for us is it maintains boundaries. And so because it makes up all of our boundaries, so it makes up all the outsides and insides of all of our organs, it experiences a lot of friction, okay? And so it has to regenerate a lot of itself, especially like the cells of your esophagus, made up of simple squamous epithelium. You have food going down your esophagus all day long, rubs up against those cells fall off, and you have to regenerate them, right? So epithelial tissue will have a high regeneration rate. So if we say it has a high regeneration rate, what is happening a lot of the time? Mitosis, so lots of mitosis. So because there's lots of mitosis, this makes cancer more likely than other tissues with a lower regeneration rate. Does that make sense? The more mitosis you do, the more chances you have to make a mistake, cause a mutation that will then lead to cancer. Okay, I'm going to make a couple of notes about epithelial tissue cancer. And a lot of this is probably in your notes, so you can just follow along. But if the cancer is within glandular tissue, we usually put them into two different categories. They are either considered a non-secreting tumor, and this means that the cancer caused these cells to lose their ability to secrete the hormone. If they're not a non-secreting tumor, then they're going to be a secreting tumor. And in this case, cells retain their ability to secrete. So if we're talking about a secreting tumor, this is where you have more cells of that gland producing more of that hormone. So do you think you would have a hyper or hyposecretion problem with a secreting tumor? Hyper, right? You have more cells producing more of that hormone. So you would have a hypersecretion issue with a secreting tumor. And then if you have cells of your organ who now no longer can secrete that hormone, then you may have a hyposecretion problem in that case. So does that make sense, everyone? Anybody have any questions about that? Anybody still need to write this stuff down? Okay. Okay. Everybody good here? Once I go away, this goes away forever. Okay. All right, this is just showing you the diagram in your textbook, which looks much better than my drawing, but it takes you through the same steps that I talked to you about before with the portal system there. It'll give specific names to those capillary plexuses or blood vessels, but you don't have to know those. And there's for the posterior pituitary. And you can see how anterior pituitary, those hypothalamic neurons are much shorter and they go through a portal system versus the posterior pituitary where those hypothalamic neurons are much longer. They extend all the way down to the posterior pituitary, and then this just acts as a storage area for the release of those hormones or neurohormones. Okay, so for every every hormone that we talk about, you want to make sure that you know the secreting organ for that hormone. So which organ is actually producing the hormone? Obviously the hormone name, the target cell or organ of that hormone, and then the response of that target cell. So those are the things that you should be thinking about when studying every single hormone. Make sure you know these things for every hormone that we talk about. And then we'll talk about, as we go along, some homeostatic imbalances. What can go wrong when there's too much or too little of any of these particular hormones? So the first one we're going to talk about is, in this table form, is growth hormone, releasing hormone. We already discussed it a little bit. The secreting hormone is the hypothalamus. It produces the growth hormone, releasing hormone. The growth hormone releasing hormone is then going to target the anterior pituitary, and then the anterior pituitary, the epithelial cells there will produce growth hormone. And the other hormone we talked about already is thyroid releasing hormone. It is the same secreting organ, comes from the hypothalamus. It also targets the anterior pituitary, but this time the epithelial cells will produce thyroid stimulating hormone. And remember, with hormones, you are free to use abbreviations for hormones only. Thyroid stimulating hormone would be TSH. And growth hormone's easy, but if you wanted to, you could abbreviate that GH as well. There are no homeostatic imbalances that we'll talk about with these two hormones, but we will for some later ones. Okay, questions so far? Anyone still need this up? Okay. So one thing you're going to be doing in lab today and for homework over the next couple of days is you're going to have to do hormone pathways. So the way the hormone pathways go, these are flow charts you're going to have to draw out. This is the kind of the makeup that you're going to have to follow. So the first box will have the secreting organ. You'll draw an arrow. Above that arrow will be the hormone that we're talking about. And then in the second box will be the target cell or organ that hormone is targeting. And at the very end, you want to give what is the action or response of that target cell. Sometimes our flow charts are this short and this easy. Sometimes they take a couple of steps, like when we talk about hormonal stimulation, where one hormone release triggers the release of another hormone, then that flow chart is going to be a little bit longer. But the breakdown is going to be the same. The secreting organ first, an arrow with the hormone that's being released. Then the next box is going to be the target organ for that hormone, which is now going to be the secreting organ for our next target. Okay, so it's going to serve two purposes here. It's the target for the previous hormone, and it's going to be the secreting organ for the next hormone. But then you'll do another arrow for the next hormone, and then the final target cell. I forgot how to spell cell for a second. Target cell or organ. And then at the very end, you're going to give the action or response.
So that hormone to hormone would be a hormonal stimulus?
Yes, ma'am. So that would be a hormonal stimulus when you have a hormone triggering the release of another hormone. Your lecture notes today will be, it's divided out by hormones. So you'll have a box giving you all the information about that hormone and then a blank flow chart for you to then fill in. We'll do some of them together. Towards the end of the lecture, we won't go over the flow charts together, but you need to go back and fill that out with the information that you have. Okay, so growth hormone is next. The secreting organ here is the anterior pituitary. It releases the growth hormone. The target cells or organs, there's going to be a few of them here, include our liver, our bone and cartilage, our muscle, fat, and then other tissues as well. Okay, but we're going to focus more on those four, but growth hormone has lots of different effects all over the body. Now the responses for each. For the liver, it's going to spare glucose. What that means is that it's going to release more glucose into the blood, which makes sense. If you're growing and developing, you're going to want more access to glucose to make more energy to do the work to grow and develop. For bone and cartilage, we're going to have growth in bone, cartilage, and muscle. So growth hormone is going to stimulate the growth of bone, cartilage, and muscle. For fat, our body is going to mobilize fat. What that means is that it will go through what's called lipolysis. Lipolysis is the breakdown of fat. And then the fatty acids and glycerol are going to get released into the blood to be used as another form of energy. Okay, so carbohydrates or glucose, that's our main form of energy, but we can also use fat when needed. So growth hormone is going to also put fat product into the bloodstream so that cells can uptake that fat and also use it for energy for growth and development. Just another energy source. Some homeostatic imbalances. If you have too little of growth hormone in infancy, this results in what's called pituitary dwarfism. And you want to say specifically pituitary dwarfism because there are different types of dwarfism that we won't talk about in this class. But with pituitary dwarfism, these people often only grow to about 4 feet tall. And because growth hormone is not the only hormone being released by the anterior pituitary, people who experience pituitary dwarfism usually are experiencing a decrease in the production of other anterior pituitary hormones as well, not just growth hormone. And so we have a decrease in other anterior pituitary hormones. Most notably, hormones like thyroid stimulating hormone and our FSH and LH, which are really involved in reproductive development. Okay? Remember we talked about before how thyroid hormone, the presence of thyroid hormone, allows for the proper development of our reproductive structures. Does anybody remember what kind of hormonal interaction that displays? When the presence of where the production, or let's see, the function of one hormone is dependent on the presence of another. Where it's dependent on the permissiveness. Permissiveness is when the function of one hormone is dependent on just the presence of another hormone. So when you have not enough thyroid stimulating hormone, meaning you're not going to have enough thyroid hormone, and you also don't have enough of your reproductive hormones, these people with pituitary dwarfism also often also don't reach sexual maturity. So they're not going to have proper development of their reproductive organs. They're not going to have proper reproductive health. So people with pituitary dwarfism, I'm running out of room, and I'll say do not reach sexual maturity. Now, there is treatment for this. We can prescribe, not we, I'm just a professor, but they can be prescribed synthetic growth hormone as a replacement therapy. Along with probably synthetic thyroid hormone as well, just to make sure those reproductive structures are being developed properly. So because it does cause the growth of bone and cartilage and muscle and gives us lots of energy available, synthetic growth hormone is sometimes abused for those results. Okay, so like lots of bodybuilders or athletes, sometimes actors, may abuse synthetic growth hormone to get that look of being lean and toned and such. And I'll write the notes about abuse on the next page. So I'll go back. You still need it?
No, it's fine.
Okay, I'll go back. But with synthetic, I can spell synthetic. Synthetic growth hormone or human growth hormone abuse. While it may give the results that they want with the increased growth in areas, studies have been shown that synthetic growth hormone does not significantly increase strength or exercise capacity. So you may get the look of being toned and more muscular, but it doesn't really have any functional effect. And if you do abuse it, you may experience side effects or signs and symptoms, including fluid retention. The reason for this is you have more glucose in the blood, you have more fat product in the blood, and water is always going to want to follow areas that are more concentrated. So if your blood is more concentrated with solutes, water is going to want to be in the blood as well, causing more blood pressure and more fluid retention. Because of the sudden growth in their bone, cartilage, and muscle, they may experience joint and muscle pain. Because they have more glucose in the blood, what do you think they may be at risk of? Diabetes. And then if they're stimulating more growth, meaning more mitosis, what are they more at risk of as well? Cancer. So questions about growth hormone abuse? Who still needs these notes? Okay. Okay, everyone good here now? Okay. Anybody still, well, actually, we're going to still talk about this stuff. Okay, so that's if you have too little growth hormone in infancy, you're going to develop pituitary dwarfism. But there's also issues if you have too much growth hormone as well. If you have too much growth hormone in childhood, and this means before plates close, before your growth plates close, then you're going to experience something called gigantism. And I'll write the gigantism notes over here. With gigantism, these children can grow up to 8 feet tall, but they may experience enlarged organs, like specifically an enlarged heart, which is going to cause more pressure on the body. They may also experience things like joint pain because of the excessive growth of bone and joints and muscle. However, if you experience an increase or too much growth hormone in adulthood after growth plates have closed, it's called a different condition. It's called acromegaly. So gigantism is the childhood version, while acromegaly is the adult version. You're going to have the same kind of symptoms like with the joint pain and such. One big thing we see with people with acromegaly is they have an overgrown face, so their facial bones will grow more than they should, overgrown hands, and feet as well. But they'll also experience the joint pain from the increased growth in their cartilage and bone and muscle. Both for gigantism and acromegaly, they may experience a deeper voice than normal because of the increased growth of their vocal cords as well. So they'll have a much lower voice than other males. So questions about the difference between gigantism and acromegaly. It's just about when it occurs. Both of them, it's too much growth hormone. Gigantism is during childhood before plates have closed. After plates have closed, it's called acromegaly. Questions about that? Okay. Anybody still need these notes up here? Okay. So this is showing a average sized woman here. Here is somebody with pituitary dwarfism and then somebody who experienced gigantism as a child. Now, with acromegaly, like I mentioned before, which is the next picture, you're going to see lots of overgrown facial bones. So they usually have a forehead or a frontal bone that sticks out forward. They'll have a very long face, a very big chin. So all their facial bones start to outgrow. And because they are experiencing lots of growth, they may also have growth of skin. So they'll have lots of skin tags as well because of the excessive growth. So questions about, yeah.
Is there a way to treat that acromegaly?
So usually it's caused by a secreting tumor of the anterior pituitary. So with acromegaly, it's usually caused by a secreting tumor of the anterior pituitary. So the option there would be surgery, and that has to be on a case-by-case basis on whether it's safe enough to do surgery on the anterior pituitary gland in order to remove that cancerous tissue, or if like chemotherapy is an option. But this is your brain, which is very sensitive, so it would be on a case-by-case basis on how it would be treated. Yeah.
Even if that were the case, would it go back to normal, you think?
Yeah, I mean, some things may start to atrophy, but you're still, those facial bones are not going to go back. You're going to still have those features. Yeah, but it'll stop the growth once it's treated. Yeah. Any questions?
Is the same thing for the gigantism? Like, it's a tumor on the anterior part?
Yeah, usually. Yeah.
I knew a child that had a pituitary tumor,
Uh huh.
and he had to have numerous surgeries.
Yeah.
And his growth, he was looking like he was 15, but he was only literally like 5 years old.
Uh huh.
Another thing that he experienced was an increase in urinary output.
Oh yeah.
He had to wear a diaper. It was out of control.
Yeah. Well, especially with all the fluid retention and then trying to get rid of that fluid, and yeah. Questions about that? All right, so for growth hormone, the hypothalamus is a secreting organ here. It's going to release growth hormone releasing hormone. That's going to target cells of the anterior pituitary. The anterior pituitary is then going to release growth hormone. And then growth hormone is going to target your liver, bone and cartilage, muscle, fat, and other tissues in order to cause these responses. The liver spares glucose, bone and cartilage grow, muscle grows, and then we mobilize the fat or we break it down to release it for more energy. And I'll give you a second to fill that out. Say it again? Over the weekend we what? Oh, yeah. Is everyone ready for their quiz today?
No. Regarding the Kahoot, are those extra points or no?
No, those are just for practice. But if you do them many times, I will pull a question from the Kahoot. So it's beneficial to do them. Okay, who still needs this up? Okay. This is just a diagram in your book. So GHRH, here we go, causes the release of growth hormone from the anterior pituitary. Then we're going to have some direct actions where we have an increase in blood glucose, an increase in fat breakdown, and then indirect actions is that what's going to happen is the liver is going to produce things called insulin-like growth factors that cause the growth of your bone, cartilage, and muscles. You don't have to know the difference, just know this. Okay, but in your textbook, it does specify between direct actions and indirect actions. Okay, so now thyroid hormone. So we already talked about thyroid releasing hormone. The secreting organ there is the hypothalamus. And then that thyroid releasing hormone is going to target cells of the anterior pituitary, and then the anterior pituitary cells, epithelial cells, can produce thyroid stimulating hormone. So then that thyroid stimulating hormone, the secreting organ then is the anterior pituitary gland. That thyroid stimulating hormone is going to target the thyroid gland. The thyroid gland will then produce thyroid hormone. So our T3 and T4. T4 is our thyroxine. But again, you can just group them together and call them thyroid hormone. We'll talk about Graves' disease here in a second. And then after the thyroid gland makes thyroid hormone, our thyroid hormones, which again come from the thyroid gland, are going to target most of our body cells. And that's in order to increase cellular metabolism. So the reason why thyroid hormone targets most body cells, because all of our cells have the ability to metabolize. So our thyroid hormone is going to be controlling the work of all of those cells. So Graves' disease is when an autoimmune immunoglobulin, so it's going to be an antibody protein that imitates thyroid stimulating hormone and causes overstimulation of the thyroid gland and hypersecretion of the thyroid hormones. So I'm going to have a little diagram to show you how that works. Anybody still need to fill in these spaces? Okay. So how the regulation of thyroid hormones go. Again, the hypothalamus releases thyroid releasing hormone. The anterior pituitary gland will then release thyroid stimulating hormone, and then the thyroid gland will release those thyroid hormones to most of our body cells in order to increase cell metabolism. Now let's say we have an increase in the amount of thyroid hormone. What's going to happen, these dashed lines over here, these are showing a negative feedback mechanism. So when we have too much thyroid hormone, there's going to be a negative feedback on both the anterior pituitary and the hypothalamus. Okay? We're going to have them decrease the amount of these hormones being produced. So again, when we have too much thyroid hormone, there's a negative feedback loop that's going to cause the decrease in thyroid releasing hormone, a decrease in thyroid stimulating hormone, and that should cause a decrease in thyroid hormone because there's less of that stimulation, less of that hormone production. Does that make sense, that negative feedback loop? Questions about that before I move on to Graves' disease? Okay, so what happens? So let's say this is a thyroid gland cell. This thyroid gland cell has a receptor for thyroid stimulating hormone. And every time thyroid stimulating hormone binds, it causes the release of thyroid hormone. Okay? So let's say this guy right here is thyroid stimulating hormone. But let's say we have a mimic that can also fit in that receptor. And this is our antibody like protein. You can also refer to it as a TSH mimic. So what Graves' disease is that it happens during an infection. So I'll write over here, Graves' disease. Happens during an infection. So you get an infection. One of the more commonly related viruses to Graves' disease is the Epstein-Barr virus that causes mononucleosis. So many times somebody can get the Epstein-Barr virus and it causes their immune system to produce this antibody-like protein. Okay? It's made by the immune system, meant to fight off the virus, but only certain people are more prone to producing this antibody-like protein, so there's a genetic factor to it. So what ends up happening, they get an infection, they produce this antibody-like protein that is just like TSH. And so what ends up happening is we have this negative feedback loop, right? If we have enough thyroid hormone, then we should have a negative feedback on the anterior pituitary and the hypothalamus to decrease all of these hormones. Okay? But what if we have this antibody-like protein that is continually binding to this TSH receptor and causing the thyroid gland cells to continually put out thyroid hormone, even though there's not a whole lot of thyroid stimulating hormone around. We've already done negative feedback on there. There should be very little thyroid stimulating hormone around if we have enough thyroid hormone. But we have this mimic. We have this imposter that's acting like thyroid stimulating hormone that is continually stimulating the thyroid gland cells to produce thyroid hormone. Okay, so we're having a hypersecretion of this hormone because there's this imposter acting like TSH and causing the release of that thyroid hormone, even though we don't have TSH around. Yeah?
Professor, you said this happens during an infection. What type of infection do you mean?
So it could be any kind of bacterial or viral infection. The Epstein-Barr virus, like I said before, EBV, it's one of the commonly linked viruses to Graves' disease, but it can be any bacterial or viral or fungal infection that just causes your immune system to make this particular shaped antibody. Yeah.
Is the mimic produced by the thymus? Because you said the thymus is what produces the antibody.
Well, your thymus produces it helps develop your T cells.
Oh, okay.
The antibodies come from your B cells, which we'll talk about more in the immune system. But it's just your immune system makes these antibodies that are meant to fight off the virus, but they happen to be shaped just like thyroid stimulating hormone. And so therefore they can stimulate the thyroid to produce more thyroid hormone even when we don't want it. Okay? So with these people, that experience Graves' disease the signs and symptoms of these, and this is a good place to talk about the difference between signs and symptoms. Signs are things that a doctor can verify, or a professional, medical professional. While symptoms are patient provided. So for example, like bruising would be a sign versus fatigue would be a symptom. Only I can tell the doctor that I feel fatigued. Okay? Only I can tell the doctor I feel nervous, or those kinds of things. So the signs and symptoms involved with Graves' disease, do you think they're going to experience an increase or decrease in metabolism? An increase, right? Their thyroid gland is still being stimulated to release thyroid hormone even when we don't want it to. Doesn't matter what negative feedback is happening, we have this mimic that's going to be constantly stimulating the thyroid gland to produce thyroid hormone. So they're going to have an increase in metabolism, which may lead to sudden weight loss, they may experience an increase in heart rate or irregular heartbeats. They may experience sweating, which heart rate and sweating would be a sign. A doctor would be able to see if they're sweating just sitting there. Nervousness, this would be a symptom. And then it happens to affect the connective tissue, CT for connective tissue, behind the eyes, causing something called exophthalmos. And it's spelled just like that, exophthalmos. And that's bulging eyes. So I'll show you a picture of that next. So in people with Graves' disease, their thyroid stimulating hormone levels are probably really, really low. But because they have this mimic, their thyroid hormone levels will remain high because their thyroid gland is continually being stimulated to produce that hormone. Questions so far? Anybody still need these signs and symptoms up? I cannot drink when there's a lid on it. Okay. So this is exophthalmos. So for whatever reason, Graves' disease affects the connective tissue behind the eye, causing these bulging eyes. This is a sign of Graves' disease. So any questions about Graves' disease? Okay. So the flow chart for thyroid hormone is that we have the hypothalamus produces thyroid releasing hormone. That's going to target the anterior pituitary and cause it to release thyroid stimulating hormone. And then thyroid stimulating hormone targets the thyroid gland to produce our thyroid hormones. And that's going to target most of our body cells in order to increase metabolism. Okay. Questions about thyroid hormone? All right, so our thyroid gland is located around the trachea, right below the larynx. And Our T3 and T4, if we go back just a little bit. The 3 and 4 refer to the number of iodines. So T3 will have 3 iodines on its chemical structure, while T4 will have 4 iodines on its chemical structure. Yeah, of course. Wait, this one?
Yes.
Okay, go ahead. Okay. So we're going to talk a little bit about iodine in thyroid cells. So here is, you don't have to know this pathway, but this is just showing you how T4 has 4 of those blue structures there. Those are iodines. T3 will only have 3 of them. But how the thyroid gland cells produce lots of thyroid hormone with all of this iodine is because, I'll draw an arrow here. Thyroid cells contain 30 times more iodine than the blood. So we have a relatively low concentration of iodine in the blood, while we have a relatively high concentration of iodine inside the cell. So how do we keep, or which transport mechanism do we use in order to keep that concentration gradient moving in that direction, from going from low to high concentration? Active transport, right? So in order to create an uneven balance, because usually the body wants to be in equilibrium, wants to have equal concentrations of solutes on either side of a membrane. But in this case, we need to make sure there's lots of iodine inside the cell so that the thyroid gland cells have enough iodine to make their thyroid hormone. So we have to keep this uneven gradient here. And the way we do that, we maintain the gradient via active transport. And what's active transport going to require? ATP. Everybody okay with that? Okay. Now, if you lack iodine, you may experience an enlarged thyroid like we talked about on Wednesday. What is that called? Goiter. Okay, the next hormone's pretty easy, and I don't do the flow chart for this one. You should be able to figure it out yourself. But the anterior pituitary produces prolactin. That prolactin is going to target what if it's for milk production? Mammary glands. And then you should be able to use that information to fill in your flow chart. And then remember, it's for milk production. So next we're going to talk about the gland or the hormones of the posterior pituitary, that oxytocin and antidiuretic hormone. So for oxytocin, it's released by the hypothalamus / posterior pituitary. And do not pack up yet. I still got 5 minutes. But the hypothalamus and posterior pituitary are going to release oxytocin. The oxytocin is going to have 2 targets. It's going to target the uterus, specifically the smooth muscle of the uterus, in order to cause contraction of the uterus to expel the fetus during childbirth. And then it will also target the mammary glands to expel breast milk, which, what did I say that was called? Let down. So how I remember the difference between prolactin and oxytocin: prolactin is for production. Okay, while the oxytocin is for the letdown. Now, if needed, you can be administered synthetic oxytocin or Pitocin to induce labor if needed. That is just a synthetic form of oxytocin. So in your lecture notes, it asks you, during what life events is oxytocin released? So during what events, and I'm going to write it down so you guys can follow along. It's going to be childbirth and also breastfeeding. So the trigger for childbirth, the trigger is going to be the stretching of the uterus. So as baby makes its way down towards the birth canal and stretches that uterus. For breastfeeding, the trigger there would be suckling. So baby suckles on mom's breast to cause that letdown. And so for both of these, the stretching of the uterus and suckling that causes the release of those hormones, okay, what kind of stimulus is that? Okay, so let's think about this. Baby suckles on the breast. It's going to be neural, okay? Baby sucks on the breast, okay? That causes stimulation at the mammary glands, which causes the release of oxytocin, which then can lead to the letdown of that breast milk, okay? Stretching of the uterus is also going to be neural. You talked about, should have learned about like mechanoreceptors that detect stretch, right? That's part of your nervous system. So baby makes its way down towards the birth canal. The uterus stretches. That sends signals up to the hypothalamus and posterior pituitary to release oxytocin to cause contraction of the uterus and further stretching. Okay? And further stretching, and further stretching, and further stretching. What kind of feedback would that be? Positive feedback until the baby's born, right? Okay, is everybody okay with that concept? Okay. Can I take off my... It's neural stimulus, a neural stimulus. By suckling, releasing the oxytocin, and stretching of the uterus, releasing oxytocin, that's a neural stimulation. And I can take away these notes? Okay. All right, so I'll just talk about this real quick and then we'll continue in lab. But the posterior pituitary here also, and again, you want to include both hypothalamus / posterior pituitary. They're both working together. It's going to release antidiuretic hormone. The antidiuretic hormone is going to target our kidney tubule cells, the ones that are making urine. Okay, because antidiuretic hormone, if you look at the notes over here, diuresis is urine formation. And so an antidiuretic is going to stop urine formation. Okay, so what ends up happening with antidiuretic hormone is that we reabsorb more water from what would have become urine. We're going to take that water and we're going to put it back into the blood. Okay, so we're making urine, but let's say we have like low blood pressure. We need more water in our blood. We're going to take that water from the urine and put it back into the blood. And so this results in less water loss because now that water is not going to become urine. That water is going to go back into the blood. So we're going to retain that water, which puts more fluid in the blood. And so what do you think that does to blood pressure? If we put more fluid, more water into the bloodstream, is that going to increase or decrease blood pressure? Increase. Okay, it's just like airing up a balloon. The more air that we put into the balloon, more pressure it develops until it can't withstand anymore and then it pops. Okay, so ultimately, and there was an error in the lecture notes, so you want to put a decrease. Oh, sorry, no, it is an increase. Sorry, I'm lying to you. I thought, because in your lecture notes it says decrease, huh? Yeah, so change that. I fixed it here, but I didn't fix your lecture notes. So erase the decrease and put increase. But ultimately causes an increase in blood pressure. Ooh, one more chance for extra credit in this class. If you can catch a mistake, because these lecture notes I wrote by myself about a year ago, and when you've written it yourself, it's hard to see the mistakes until you come up to them. So I will give 1 point of extra credit to anybody who finds mistakes in here before I find them. So just send me a message And then I'll let you know if I've already corrected it or not. All right. And so that's all I want to say about that. Yeah, antidiuretic hormone causes more water reabsorption into the blood, meaning more fluid in the blood, so we increase blood volume and also increase blood pressure. Okay, we will finish this in lab and we'll review on parathyroid hormone and other stuff. Okay, so your parathyroid glands are on the back of your back of your thyroid gland. So your thyroid gland, we said, was at the bottom of the neck, right underneath the larynx, covering the trachea. On the posterior side, though, we have 4 parathyroid glands that are going to produce parathyroid hormone. So then the secreting organ is the parathyroid gland. The hormone is parathyroid hormone, abbreviated PTH. We have 3 different targets. Again, you should already be familiar with this. Our osteoclasts and bones, our kidneys, or you can also say kidney tubules. Either one's fine. And then our intestines. So at the osteoclasts, we're going to have them stimulated to increase bone resorption. Same thing as bone breakdown. So we break down the bone and release the extra calcium into the blood. At the kidneys, we're going to increase reabsorption of calcium at the kidneys. So we're moving more calcium from the filtrate, which is our pre-urine, back into the blood. So make sure that when we're talking about any kind of absorption happening at the kidneys, it's a reabsorption. The reason for that is because when we make urine, all of these solutes and such go out into the urine, but sometimes we want to recapture those. So sometimes we may get rid of some calcium through our pre-urine, but then say, hey, we need more calcium. Let's take that calcium from our pre-urine and put it back into the blood. Okay, that is a reabsorption because it was already in the blood. We took it out to make the urine, and then we said, okay, never mind. I want to keep some of that calcium still, and we put it back into the blood. Okay, so it's a reabsorption because we already had it. We're just putting back into the blood so that we don't excrete it. Versus the intestines would just be absorption. This is the first time we're absorbing this calcium from the food that we ate. Okay, so absorption at the intestines, but reabsorption at the kidneys. So, So at the intestines, it promotes the activation of vitamin D, and remember, vitamin D is required for that calcium absorption at the intestines. Okay, any questions about that? I'll give you a second to write that down. Okay, who still needs these notes up? Okay. So how this breakdown or how this pathway goes, we experience hypocalcemia, so low blood calcium. That's going to trigger the parathyroid glands to then release parathyroid hormone. So if that stimulation of hormone release came from low blood calcium, what kind of stimulation is that?
No.
Humoral. Yes. So what type of stimulus shown here? It's a humoral stimulus. And so once parathyroid hormone is released, it's going to target our osteoclasts, our kidney tubules, and our intestines to all increase calcium levels in the blood. Questions about that? That should be reviewed. So next we're going to move on to our adrenal gland. We'll start with the adrenal cortex and then we'll move to the adrenal medulla. The adrenal cortex is just the outside region of the adrenal gland. Just like with the cerebral cortex and medulla, cortex is the outer region, medulla is the inner region. So hormones of the adrenal cortex, all of these are going to be lipid-based hormones. So really, these are the only lipid-based hormones that we're going to talk about this semester, except for the other sex hormones that we talk about with reproductive. But these and our sex hormones are really our only lipid-based hormones we'll talk about in this class. They are going to have a long-term response, as we learned on Wednesday, because they're going to go inside of the cell and then inside of the nucleus to activate genes to then put out a protein, which is a longer process than our second messenger system. And also they're cleared by the liver, which takes longer, so they're in the body longer as well. And then our adrenal gland is actually protected by an outer capsule. You can see that by the layers here. There is a capsule that protects the adrenal gland, not only, well, it's from infection, really, so that infection can't spread to the adrenal glands. But what if cancerous tissue grows and bursts through that capsule? What's going to happen with those cancerous cells? They're going to spread. What's the term for the spreading of cancer? Yeah, they're going to metastasize. So if we have cancer growing in the adrenal gland, it bursts through the capsule, those cancerous cells are going to spread all throughout the abdominal cavity, causing metastasis. Okay, so the first hormone of the adrenal cortex is going to be aldosterone. The target cell or organ are our kidney tubule cells. And what they're going to do is they're going to increase sodium reabsorption. So we're going to take sodium from our filtrate, which again is our pre-urine, and we're going to put it back into the bloodstream. Now, one thing you should know, we're going to talk about this a lot this semester, is that sodium and water are closely tied to each other. So pretty much anywhere sodium goes, water wants to follow. So in this case, when aldosterone triggers the kidney tubule cells to put more sodium into the blood, water is also going to follow it into the blood. And so if blood sodium increases, water follows, blood volume is going to increase, and therefore blood pressure will also increase. So it works very similarly to the antidiuretic hormone that we talked about, but antidiuretic hormone causes specifically the reabsorption of water, while aldosterone causes the reabsorption of sodium, and water happens to follow it anyways. So they're both going to lead to water reabsorption and therefore an increase in blood volume and an increase in blood pressure. But ADH triggers water reabsorption specifically, and aldosterone is sodium specifically. But they're both going to lead to an increase in blood volume and blood pressure. Okay. Now, one thing we're going to talk about later is something called the renin-angiotensin-aldosterone pathway. But we're not going to get there until we get to blood vessels, and we'll talk about it again in urinary and then once more again at the very end of the semester. So we're going to get into that portion a little bit later. So questions about aldosterone? Okay. The next hormone from the adrenal cortex, and again, remember these are all lipid-based hormones, is going to be cortisol. Cortisol is known as our stress hormone. And its target cell or organ is going to be most body cells. Because all or most of our body cells can all experience some kind of stress. Okay? Whether it's mechanical stress, chemical stress, osmotic stress, all kinds of stress. So the response for cortisol is many different things that we'll talk about. But one of those things is to suppress the immune system to prevent an overactive inflammatory response. So cortisol will depress your immune system or suppress your immune system. So when we have too much cortisol, this can result in what's called Cushing's syndrome. This is the most common medically induced condition from giving patients corticosteroids to treat immune disease or prevent transplant rejection, or cortisol shots are also given for general inflammation. People can come in with inflammation, maybe back pain, maybe joint pain, muscle pain, and instead of finding the cause of it, many doctors will just prescribe a cortisol shot to reduce the inflammation and then reduce the pain. But if you are continuously receiving cortisol shots, that increases your amount of cortisol and therefore can lead to Cushing's syndrome, okay? Or Cushing's disease. Either one. So it may be beneficial if your doctor first prescribes a cortisol shot, maybe ask if there's some other way to treat your underlying pain, because you do not want to get into the habit of constantly getting cortisol injections. So not only is it for treating autoimmune disorders or preventing transplant rejection, but sometimes it's given for pain related to inflammation. So again, like back pain, joint and muscle pain. It's also given sometimes when you have a severe allergic reaction, in order to decrease the inflammation. Decrease your inflammatory response comes from your immune system. So if we suppress the immune system, we're going to decrease that inflammation. Now, one other thing that cortisol does besides suppress your immune system is mobilizes fat. So we talked about this before with growth hormone as well. So mobilizing fat means that we break it down and release into the blood for energy. So as another energy source. Now, one thing about your body is your body does not know the difference between different types of stress, okay? So your body does not know the difference between stress from starvation, or let's say you haven't had a meal in a few days, or you don't know where you're going to be sleeping for that night. That kind of stress, okay, life-threatening stress, your body cannot decipher that between I have a big exam coming up this morning and I'm really, really freaking out about it. Hey, your body can't tell the difference really between those two things. And so either way, you're going to release cortisol, right? And so your body will mobilize fat when you release cortisol in times of stress, so that in case that stress is that you don't know where your next meal is coming from, you have this extra bit of energy in the form of fat in your blood that your body can use until your next meal. However, if you're releasing cortisol or even getting cortisol injections for something like pain, where you don't necessarily need the extra energy or the fat as an energy source, then what ends up happening is that this mobilized fat goes and deposits itself in other parts of the body. Okay, so mobilizes fat. And then in Cushing syndrome, when you have too much of this cortisol, that unused fat goes to other sites in the body. Many times it goes to the upper back or lower neck, causing something called a buffalo hump. So a buffalo hump is a sign of Cushing syndrome. Amy Schumer just recently came out that she actually developed Cushing syndrome from the amount of stress that she experienced from fat shaming. And then it just barely came out that she was diagnosed with Cushing syndrome because of the amount of stress she experienced from being in the public eye. So this is what a Cushing syndrome buffalo hump looks like. So this is the patient before the onset of Cushing syndrome and then after. So that buffalo hump. So again, your body, when you're stressed, releases cortisol, which causes a release of fat. But if that fat is not used, then it deposits itself in other sites in the body. Yeah.
Is it true you can like raise your natural cortisol levels like by doing certain things like drinking coffee in the morning before like eating breakfast?
Yeah, so lots of different things can raise your cortisol levels. So caffeine puts a lot of stress on the body, also lack of sleep, also just mental stress as well. So if you are overworked and not taking enough time to relax, that can also increase your normal cortisol levels. Lots of different things. Messing up your eating cycle as well. If your body's used to eating at certain parts of the day, certain times of the day, and then you switch that up, maybe skip a meal, that's also going to cause some short-term stress as well. And so lots of different things can cause stress in the body. So managing stress is one of the really big things that if you're trying to like lose weight, is a really good thing to do, is to try to manage your stress first, because that might be what's keeping you from losing weight, because stress makes you mobilize fat and keeps fat around. And so our last set of hormones from the adrenal cortex are androgens. Androgens are basically pre-testosterone and pre-estrogen. So as soon as androgens are released from the adrenal cortex, they get converted into female and male sex hormones. The target cell organ are some body cells, not all, very few around the body, depending on what the response is. But the response is different for males and females. It has a bigger effect in females, so it's responsible for the female libido or sex drive. It's also responsible for axillary and pubic hair in females, but these androgens have little effect in males. It has a lot of influence in development while they're in utero, so while they're a fetus. These androgens have a big role in male reproductive development, but once they're an adult, it has very little effect on males. Oh, I already wrote that over here. So no, converted to testosterone or estrogens once it's released. That's all you have to know about androgens, because we're going to talk about sex hormones in great detail at the end of the semester. And so hormones for the adrenal medulla, this includes our catecholamines. So your epinephrine and norepinephrine as a group together are called catecholamines. So you did not have to know that in BIOL 32, but you have to know it now. So together as a group, they are called catecholamines. And then they are amino acid-based hormones, and therefore they're going to be short-term responses because they use the second messenger system, which has already made products to carry out the response, and it's cleared by the kidneys, which is a much quicker process than clearing through the liver. And that should already be in your notes. And so our catecholamines, which are the epinephrine, norepinephrine, they target the heart, the respiratory muscles, and the blood vessels. And the response is at the heart, it's going to increase your heart rate, because remember, this is for your fight or flight response. So we're going to have an increase in heart rate. We're going to have an increase in your respiratory rate at the respiratory muscles. And for vessels, we're going to have an increase in blood pressure. And this is by smooth muscle contraction. So the smooth muscle layer of your blood vessels will contract, which is going to constrict the blood vessel, increasing blood pressure. And I promise we're not going to lecture in lab all the time. Most days will finish in there, but endocrine is a lot. Is everybody good here with epinephrine or norepinephrine? This diagram is just to show you the difference between these two. These are your fight or flight hormones. Your catecholamines and your cortisol are both for stress. But know that your catecholamines are for short-term stress. So this is your fight or flight response. So this is for an immediate stressor. You're scared or you're embarrassed or what have you. This is your fight or flight. So this is a short-term stress response where catecholamines are released to increase heart rate, increase blood pressure, open up your airways, make some glucose available, and increase your metabolism. Prolonged stress, so this is long-term stress. This is through cortisol. So cortisol is for long-term stress. And so your kidneys will retain water, which is going to increase blood pressure. You'll have fat, mobilizing fat. Your blood glucose will also increase and your immune system will be suppressed. The only thing I need you to know here is your catecholamines are for short-term stress, while your cortisol is for long-term stress. Your thymus, again, remember the thymus gland is only found on the infant model because your thymus atrophies as you age. The hormone it produces is called thymosin, and its job is to activate our T cells. And so in this case, the secreting organ is the thymus gland. The hormone is thymosin. The target cells are our T cells, and the response would be immune system activation. And then we have one more thing to talk about before I assign you your homework. All right, so the last thing is something we already talked about, which is insulin and glucagon. So the secreting organ for both of these is, which is the organ that secretes insulin and glucagon? Pancreas. So it's going to be the pancreas for both. So insulin is going to target both our tissue cells and our liver. At the tissue cells, it's going to cause our tissue cells to uptake glucose. So there's extra glucose in the blood, right? Because insulin is released when we have an increase in blood glucose. So our tissue cells are going to uptake that extra glucose either for cell use, or if they don't need it, they'll form fat, okay? And they'll deposit fat as what kind of tissue? It's fat, adipose, okay? So they'll store it as adipose tissue. And then insulin at the liver is going to link glucose, those extra glucose molecules, together as glycogen for storage. So you should know that fat is long-term storage, which is why it's hard to get rid of, and glycogen is a short-term storage of glucose. And then one thing you didn't know from before is that it's specifically beta cells that produce insulin when we have high blood glucose. So that B stands for beta. And then on the flip side, when our blood glucose decreases, it is alpha cells of the pancreas that release glucagon. Glucagon, though, only has one target, that is our liver. And it's going to cause the liver to then take that stored glycogen and break it down into individual glucose molecules to release into the blood. And we'll also have some synthesis of glucose from other sources like fat and protein. More so fat, though. So if these two hormones both act on the liver, but one is for storing glucose and the other one's for releasing glucose, what kind of hormone interaction is that? Yes, it's antagonism. Or you can say that they are antagonists to each other. So is everyone okay with that? Okay. So then your homework, anybody still need these up? Okay, so your homework is to do the negative feedback teeter-totter. So all you're going to do is take this diagram, which we already went over in class last time, and I just want you to recreate it. Just redraw it, draw it all the steps, because it will be asked of you on the next exam. I may not have you draw it completely out. Maybe I will, maybe I won't, but you'll definitely at least have questions about different parts of this pathway, so you make sure you know it well. Your other homework as our critical thinking hormone pathway. You're going to take all of the hormone pathways from this lecture and rewrite the pathways on a single sheet of paper. This should be a working document that you will add to as we discuss more hormones throughout the semester, and this assignment is due at your next class meeting. They're both due at your next class meeting, so on Wednesday. So you can look at this, but I want you to take a picture because I want you guys to do it on your own. But you're going to just make a kind of cheat sheet. You can't use it on an exam, but a study sheet, I'll say, of all the hormones and all those pathways. So take the pathways that you have in your lecture notes and just make one complete study sheet. Okay? And then you will add to it as we go on this semester, because we will be adding more hormones as we go through the semester. Okay, so those are your 2 bits of homework. For lab today, we're going to go through the first part together, and then the rest of it you should be able to figure out because we talked about it already during lecture.